So just a few words about myself. I spent 35 years in the NHS between 79 and 2014, and for the last 25 years I've had an interest in joint hypermobility, which really came about because I found myself in contact with a physio who had hypermobility, and every time I sent a patient to her, they came back and they were sort of sorted out by and large. So that was a great help, and throughout my career I learnt more and more on the way, and of course it's an exciting time for hypermobility because everything seems to be coming together, and I think a lot of us feel very optimistic about the future, although of course at the moment there are lots and lots of loose ends. I now have a new existence, which is I do clinics at the One Hospital at Ashford and in Canterbury, and I do lots of education. I'll talk to anyone who's prepared to listen to me, and I'm really glad that you've stayed for this session because I really hope that this will be worthwhile for you. So I'm a hospital governor, so that involves holding the executive board of the trust to account, which is an interesting thing to do on a voluntary basis. And I'm a medical advisor to the HMSA and the clinical lead for the Kent Hypermobility Network. But you might say, well, what is a rheumatologist talking about mindfulness for? Any ideas? Okay, well, in around about 2010, having always been interested in psychological health and having had probably 2 days off in 25 years, I became very, very anxious and got burnt out. And I can empathise with having a persistent tachycardia. I can empathise with insomnia. And eventually I decided, well, time for a change. So I left the NHS and had to take it easy for a while. But the thing that catalysed the changing of my thinking back to normality, if you think I'm normal, was that I went on a mindfulness course, and I found that very helpful. It didn't happen quickly, but I got back to it. So I've now got a kind of new existence, and I know for many of you, you've probably been through this process of a major event, or it might have been a long event, leading you to a point where maybe you have to completely make some major decisions in life about what you're doing next. So I have some empathy there, and I just thought I'd tell you my story so that you feel that I'm not talking out of my specialty, but all of what I'm going to tell you is evidence-based. So here we go. 3 important things to talk about. Firstly, mindfulness. Secondly, the Alexander technique. And thirdly, what we're doing about improving services. Before we kick off, though, let's just think a little bit about the obstacles to good care. Firstly, the way we live, and I think we all know a lot about that, but I'll just come back to that later. Secondly, and we've heard it in the audience today, some health professionals don't help us on the way. Thirdly, the biggest problem, and the one that I'm trying to tackle with the Kent model, is this issue of delayed diagnosis. And then fourthly, not knowing the best options, and that's ourselves and, of course, the medical professionals. The knowledge isn't out there. Okay, so let's talk about the problem with the doctors. Firstly, if you're referred to a specialist who is an organologist, like a cardiologist or a gastroenterologist, fine if you've got a problem in that area, you'll get a good opinion. You'll get a very good cardiac workup or gastro workup. But if you miss the target and you're seeing somebody who's the wrong person, or that person doesn't understand the links that we're trying to tell everybody about, then you'll have a wasted consultation. Secondly, rheumatologists, my lovely colleagues, the emphasis of rheumatology has shifted from being a good all-rounder to being a rheumatoidologist, with good reason, because we can now treat rheumatoid arthritis effectively. So they're busy giving very expensive medications, and people are very much better off with rheumatoid, but it's kind of made it more difficult for them to think about hypermobility, even though probably 10 to 15% of those patients with rheumatoid have hypermobility as well. Now there's a thought. Thirdly, you've got the disbelievologist, and these are people that are either cynical or they just don't have enough education to recognize the symptoms that you're describing. You must be imagining this, and every time I see somebody, there's always this thread of, I've been talking about this for years and nobody's been listening to me. Okay, so just a quick word about perspectives. Within this room, when we look at an elephant, and whether you're a GP or a consultant, we all have a slightly different perspective. And one of the things we've realised recently, in particular, and Emma's going to talk about this tomorrow, is that the GP perspective is different to the rheumatologist perspective. And that's important because rheumatologists see patients that come to you with musculoskeletal symptoms, but in general practice, you're going to be seeing much more of the fatigue and the fibromyalgia and the softer presentations. And of course, if you present with irritable bowel syndrome, you'll probably go and see a gastroenterologist. And the chances of a gastroenterologist understanding the link between irritable bowel and hypermobility is minuscule, really. But we're going to try and change that. So this is what we're looking at. I hope you can all see that, really. This overlap of fibromyalgia, chronic fatigue, hypermobility syndromes, and all of the associated things that we've talked about today, and then the relatively new kid on the block of mast cell activation. And we're trying to work out how this all relates. And this is, I'd like to thank Alan Hakim for this slide. This is one that he showed at the masterclass recently. We've had some masterclasses in Kent. And I think that's how we see about the relationships. We're not sure about how this all ties together yet. Okay, so my approach is to give time and information. That's the first thing. I'm lucky now, because I work in the private sector, I can actually give a new patient an hour in time. Now that's different to the NHS, where if you're lucky, you'll get half an hour. But one of the important aspects of the initial consultation is validation, and it's empathy, and it's hope. So many people I see have been somewhere and somebody's told them that you've got a progressive condition and nothing's ever going to be right. I'm sure you'll sort of relate to that. That's not particularly helpful. You have to give people hope, I think. So, key to this, and we'll be hearing more about this tomorrow from Jane, specialised physiotherapy. And with specialised therapy, I mean, you probably are aware that 90% of the physios really don't have a full grasp of hypermobility and how to treat it. And I don't think that's an exaggeration. But those who do will have an in-depth knowledge of things like anatomy of the neural system and the myofascial system, muscle balance, all of the things that you need to have an integrated, holistic approach. Then we're talking about addressing psychological well-being. It's the thing that really does get missed in the NHS unless you happen to have clinical psychology services. And where I come from in Kent, you won't find many clinical psychologists, certainly 20 years ago, when I started down there, none at all really. Moving on to optimise movement and thinking, and that's where I've become interested in Alexander lessons, and we'll be talking about that. And of course the emphasis on self-management and support, giving everybody the tools they need to look after themselves. And the final thing about my approach is that this is not a one-stop clinic that you've got to have follow-up. People need to be followed up to a degree until they're confidently self-managing. And then if they fall into a crisis, back in for some more help. So the tools in the box, we all need a toolbox. I've mentioned specialist physiotherapy, and I think that means direct, rapid access and maintenance. It's no good going backwards and forwards through an NHS queue if you need physio now. And I think it's really important if you have an injury to get in quickly to a physio. My son is somewhat hypermobile, not massively so, but throughout, he's a hockey player, and throughout his teenage years, every time he had an injury, I was in a fortunate position to get him into physio quickly, somebody who knew what to do. And it was so easy to sort it out. So he didn't develop cumulative injuries, and he's still playing at a high level hockey at the age of 25 now, and is fit as a fiddle. But that message about treating injuries properly, not just going to the GP and having some anti-inflammatories and waiting for it to settle down, that's not a good way to heal. Mindfulness, enhanced psychological well-being, that will be the first thing we'll talk about. Alexander is a skill for life. I think it should be for everyone, really, but see what you think at the end of the talk. And then, of course, the other tools are the HMSA and the EDSUK and of course ourselves. We can support ourselves through groups. Patient groups are very useful if they are positive. Not so good if you get together and just catastrophize about things. It's not very nourishing, shall we say. Okay, good. So let's talk about mental health. These are health statistics from NICE. You can see the prevalence here, men and women, mixed anxiety and depressive disorder, generalized anxiety disorder, depression, phobias, obsessive compulsive disorder, panic disorder, post-traumatic stress. So it's very prevalent in the community. This is the evidence that came from New York, from Professor Balbina, to just demonstrate that anxiety is more prevalent in populations with hypermobility. And is it really surprising when you think about the noradrenaline that's flying around and other things that we've heard about today, proprioceptive difficulties, pain. So the symptoms of anxiety include, obviously, catastrophization, procrastination, negative thinking, and demotivation. And that's what often stops you in your tracks when you're trying to get on with life. And the physical symptoms are all here. You'll recognize all of these. We've talked about it earlier. Now, the problem with for the GP's perspective is if you bowl in with a whole load of this mixed in with your hypermobility symptoms, wow, what's going on here? And I've got 7 minutes to sort this out. Well, we have to set up a system that can deal with that. In other words, the GP will be at the center of management in the future if our model develops properly. But his main thing will be signposting and avoiding you going around in circles, really. Okay, now, so this is what I was like when I was burnt out, I think. A lot of thoughts. And then I had a nice little procedure that got this monkey out of my brain. And then, well, I'm much better now. So, what is mindfulness? It's about being in the moment. So the majority of you here, I think, will be in the moment. I'm certainly in the moment. I'm thinking about talking to you. I'm not anywhere else. I'm not thinking about a shopping list. I might have a glass of water, actually. That's a little bit of a distraction. Oh, that's nice. Good. Okay, so let's talk about attention and being in the moment. The attention span of a goldfish is 9 seconds. And as human beings, we manage 12 seconds. This is evidence-based. Interesting. So this guy's missing something here. And interestingly, I'll ask you a little question now. You've all been here all day. How much do you think you've been in the moment? Or how much have you missed? Shall we put it that way? How much have you missed? 10%? Put your hands up. 20%? 30%? 40%? 100%? Okay. Well, studies show that our attention, it's about 40 to 50% you miss. So this guy's sitting there, there's this big whale floating past, he's completely missed it. I'm now going to play you a video about mindfulness, and I think this will be of interest to you, so we'll see if we can get it to go. This is Professor Mark Williams from the Oxford Mindfulness Centre.
Mindfulness is a form of awareness, really. It's a direct, intuitive knowing of what's going on from moment to moment, both in the outside world and in the inside world. And it's cultivated with forms of meditation, a sort of a secular form of ancient Buddhist meditations that have been cultivated for centuries in Asia, particularly in the monasteries in Asia, but now has come outside the monastery and to the West as well, and is proving of great benefit for many, many people. One of the really important things is to establish whether mindfulness really works. And so a lot of our research has been doing clinical trials, and what we've discovered is that for people who have the most recurrent forms of depression, it halves the risk of depression over that critical 12-month period where we know that 2/3 or more would have relapsed. But it doesn't just prevent depression. Other studies have found that it enhances well-being as well, and that you don't just need to be depressed to get the benefit from this practice. There are three main ways in which people can learn how to practice mindfulness. They can either find a class in a hospital or a meditation center near them, or they can read one of the books that usually have a CD that people can follow along for an 8-week program, or they can do it online. And it's like training an attentional muscle, really. Just like you don't go to the gym and do one pull-up, you go over a series to actually get yourself fit. So we don't train attention in 1 minute or 2 minutes, but use 8 weeks in which people take CDs home and practice every day, and they learn where their attention is most likely to disappear from view without them knowing, and how to bring it back. So they're more in control, they have greater choice over where their attention is. One example of how small things can make a big difference is the example somebody gave. She was saying that in walking from the car park to her office, she found herself really noticing her walking, noticing as the feet touched the ground, noticing the air in her hair and on her face. And this became for her a little space where she felt she could, as it were, nourish herself at the beginning of the day. And she found that it changed her whole day, just to notice that there was a little space there in the walking. And she even started parking a bit further away from her office, thinking, this is really nice, rather than actually frantically trying to get a parking space that would save her 20 yards of walking, which is what she'd been doing. And given the way her life was spinning out of control, this was really important for her.
Okay. Now, how many of you have actually tried mindfulness or are regular meditators? Great. Good. Interesting. Okay, so that's Professor Mark Williams. There are a number of places where you can go to learn mindfulness, but there's strong evidence that it helps with recurrent depression and anxiety. And also evidence for people living with long-term conditions such as vascular disorders, chronic pain and cancer make it a very important way forward. Okay, so mindfulness training enables us to do a lot of these things which you'll see here. So it regulates your attention, so you get more focus and control and self-mastery. Regulates your emotions, so it reduces the fight, flight and freeze response, and you get a reduction in perceived stress, a more positive view, better perspective taking. And then enhanced learning and memory processing, increased working memory capacity, not impaired by stress, and better choices. Now, where's the science behind this? We'll go on to that. This is a functional MRI scan that shows what happens in the brain, for example, if you're in pain, and then when you're meditating and in pain, you can see there's a change in the image there. So when you meditate, things change in the brain. There's a change in cortical activity, which that last slide showed. There's a change in the hippocampus, which is actually the memory and learning centre. You remember taxi drivers have a larger hippocampus because they know the knowledge of London. Well, there's increased grey matter when you're studying mindfulness. And the amygdala, another part of the brain, is the fight or flight centre, and that gets smaller. Just to put that into perspective, we will. So here are these different parts that I've just described, okay? Hippocampus and the amygdala, but the difference between the baseline and the mindfulness, a scan done when you're practicing, or somebody who is practicing regularly is quite convincing. So this is not an imaginary intervention, it's a real change. The brain is plastic. It's able to change, even if you've got long-standing psychological problems, it's possible to make a change at any point in your life, really. Okay, so what happens with a meditation session? Your attention is kind of focused in the frontal lobe here, but as soon as you start meditating, you get this mind wandering. Your mind starts to wander, and then you become aware that your mind is wandering. And why am I here? And then the process of meditation is to redirect your attention back to being in attention. So this is the mindful mind. You're spending less and less time going around in circles with your thoughts, or unhelpful thoughts or whatever. Okay, good. So, there are various ways in which this can be achieved. Mindful meditation is one of them, and there are two types here: mindfulness-based stress reduction and mindfulness-based self-compassion. They're parallel formulas, really, but it's all focused around doing 10 minutes meditation a day, starting with more, but at the end of the day, it's not a big amount of time. Mindfulness-based self-compassion is particularly helpful if you are a perfectionist and you beat yourself up all the time. And I'm sure that's something which many of you may relate to, because if you're hypermobile or if you've got POTS, you won't be able to do the things that you want in the way that you want. So mindfulness self-compassion is a particular thing that's worth looking up, and I'll bring you back to the resource of that lady later. Other means, exercise. I went to talk to the chief executive in our trust about introducing mindfulness into the organisation, and after 2 years, he said yes, and we've adopted it in East Kent hospitals. But he said to me, really, I'm not sure, he's naturally mindful, but he said, I'm not sure that I actually need to do this for myself, because I get it when I'm running. And that would be true. Some people would get it, when they're fishing. Some people, in other ways, it might be when they're painting. Anything that keeps you totally wrapped up in the moment, without your mind wandering, is mindful, and it's good for your mental functions. And Alexandra is another form of mindfulness. But just a caveat here, it's not a panacea. Mindfulness is not a cure-all. It won't work for everyone. It probably will work for a lot of people. And I think the message here is to find out what really works for you. So just to give you an example of the ways in which you can learn mindfulness, I teach medical students and junior doctors, and this is something which is very helpful for busy people at work. It's the Headspace app. Who's tried the Headspace app? Good, excellent. And then there are the books, Finding Peace in a Frantic World, and of course Ruby Wax's book. Ruby Wax has got another book out now called Frazzled, which combines humour with the theory behind mindfulness. Ruby Wax, of course, had bipolar depression, was unable to work for a while, and then trained as a clinical psychologist at Oxford, and is now a mental health ambassador. So she's come full circle, and has brought humour into the equation as well. So that's a really helpful way forward. And of course, the 8-week course, either mindfulness-based stress reduction or mindful self-compassion. The course is 2 hours per week plus daily meditation. It looks forward. I think people are reluctant to make contact with psychological services because they don't want to go back into their childhood or how they got there. That's not always helpful. And in a sense, the delay in diagnosis for some people of 10 years tends to make you mad anyway. It's not your fault. It's the system that has turned you into somebody who has to keep going over the story to get it across. So hopefully earlier diagnosis will take that bit of the equation out of play. So the other thing is that it helps in the way you relate to each other in the family and with colleagues and with caring and in awareness. So this course has got a very strong evidence base that it's helpful all round, but it's not for everybody and it's not a panacea. But the government have done something useful for once, and they did produce this Mindful Nation report. Have anyone heard of this? Ah, good, right, okay. So the Mindful Nation report came out in October 2015. It's an all-party parliamentary group, and 140 MPs have now done the mindfulness-based stress reduction course. It makes some key recommendations, both in health, education, the workplace, and in the criminal justice system. So mindfulness-based courses are now available for mental health and chronic conditions. In certain areas it's patchy, but it's coming. Teaching in school, you've probably seen children having mindfulness lessons on the breakfast TV from time to time. And the kids become much less anxious. It's fantastic to see. Workplace, occupational health issues. The big problem in the NHS is, of course, burnout. GPs are retiring early. Frontline workers are finding it too much, particularly in the A&Es at the moment, very stressful. And the criminal justice system, we've got a whole load of people incarcerated, not receiving any rehabilitative treatment. The other thing I wanted to mention to you in terms of persuasive evidence that this might be valuable is the MINDFIT program for US Marines, and another interesting study. So there we are, we're actually meditating. And this study showed a change in, cognitive function and physical capability is essential in battle. You need more mental armor, and you need to be better prepared for high-stress combat situations, and it improves mood. And they said at the end of the study that just as daily physical fitness is important for the body in health, engaging on mental exercise is just important for brain fitness. So I think when you're dealing with any of these hypermobility-related disorders, it is like going into battle. You need more mental armor to deal with the day-to-day disappointments and frustrations and to help with your energy levels. So I hope I presented you with some good reasons for looking into it further if you're not already doing it. And that might just be a question of buying a book on Amazon, or it might be that you get the Headspace app, or if you've got a local teacher, I'll give you references at the end of this talk so you know where to look. So, mindfulness does three important things. It changes your relationship with pain. Wouldn't it be great to get a grip on your pain when you feel it's totally out of control? It treats anxiety and depression, and it helps you make better choices, going from striving to thriving, hopefully. Good. So you can have a little stretch now if you like. Only a stretch. Right. Okay. Well, is Hannah here? Where's Hannah? No, the other Hannah. No, she's doing another session. Sorry, Hannah. Right, okay. Hannah did this diagram for me, which was really a stickman version of evolution. And, you know, you see we've gone from this upright position where we're hunting and gathering and very fit, probably not eating every day, which is another thing, but that's another talk. And ending up on the computer, and now, of course, the iPhone. Yeah. So you can see what's happening here with your spine. Not a good plan, is it? And actually, this is a real road sign in Stockholm to warn motorists about people wandering around, okay? So, what is the eye hunch? Well, it's probably the biggest threat to our children's musculoskeletal development, okay? So, not only can you bump into things, but what it does in physical terms is compress your thoracic spine. You then have a head-forward posture. The muscles at the back of your neck tighten up. The muscles at the front become weak. You get headaches. You're also compressing the nerves going into the arms. So the eye hunch is a real entity. You'll see a lot of it. And I think we're going to be expecting a sort of epidemic of kids who, as they go into their young adult years, have musculoskeletal problems, even without hypermobility. Add hypermobility into the equation, and you don't have to look far in this room to find some fairly floppy postures, and that will bring me on to another aspect of how that can be helped. Most people adopt a posture that is comfortable, and if you're hypermobile, you'll probably be quite slouched because that's a comfortable place to be. And if I ask you to sit up, it will be probably pretty uncomfortable and not sustainable. So I'm going to tell you a little story about Angela Bradshaw. Has anyone come across Angela Bradshaw? Nice little story. As we move on to talk about the Alexander technique. Angela worked at St. Peter's Hospital in Chertsey, and she was a radiographer and did a lot of mammography investigations and developed very severe pain in both shoulders and upper arms. It was a form of work-related upper limb disorder. And she had to stop working. Now, when she stopped working, she was retired on grounds of ill health. She decided to take up Alexander lessons. And if you look at her TED talk, and I would recommend you have a look at her TED talk, but almost immediately after the first few lessons, her symptoms started to settle down when she learned to release the muscles that were overactive. And then she went on to learn to be an Alexander teacher, which is something that takes 3 years. It is not a medical course. It is not medical people that go into it. It's people who come from all different walks of life who want to learn more about posture and movement, most of whom have a story behind it, and many of whom are hypermobile. So now she's gone on, and she goes around the country now. She's got a new job. She teaches radiographers how to avoid upper limb disorder by using the Alexander technique and other appropriate interventions, some of which have been covered in the previous talk. And here he is, FM Alexander. Good-looking chap. Who knows the story of Alexander? Has anyone heard his story? No? Okay. Well, he was an orator, and he died in the 1950s, but before he died, he set up something quite unique. He was in Australia and running into difficulties with public speaking. His throat used to clam up, and his muscles in the neck were really tight, and he was trying to work out what was going on here. He spent many years looking at himself in the mirror, and he realized that it was something he was doing to himself in the way that his muscles were arranged and functioning, and he learnt to release those muscles. And the critical observation is that the neck is critical to the whole of your posture. And those atlantoaxial articulations, if they're all crunched up, all sorts of consequences follow. So he learned to release the neck and then applied the technique to the rest of his body so that the spine was literally lengthening. And I'll show you what this means graphically in a minute. And then he came over to the UK and started teaching and became noticed in the medical circles. He had the endorsement of the British Medical Association, and from that he developed a school of Alexander teaching. His work was endorsed by 2 Nobel Prize winners. This is the father of physiology, and this guy, now if you go on YouTube and listen to his acceptance speech when he got the Nobel Prize in 1962 for ethology, which is a form of physiology, he spent most of his time talking about Alexander and the technique and what happened when his family tried it. Very interesting endorsements. So what's going on here with Alexander? We're talking about posture, but it's not just about posture. It's about the way we move. It's about the way we think. So that's normal posture, yeah. That's me. Oh, no. Right. And then, of course, in the army, of course, they're very upright, but it's not good posture, yeah? So we're aiming to get back to much more normal posture. The other thing is we're also not symmetrical, are we? So we can get, when you're about 3, if you look at a little kid, they will have practically perfect posture, but as you go through life, you pick up bad habits. You start sitting down, you start reading. You start having a phone. All these things completely deconstruct our natural good posture. And then you get the head forward phenomenon. The actual weight going through the spine here is incredible once you get to this head forward situation. And so if we can get you more upright, the head weighs about 12 pounds, but by the time it's leaning forward, it's multiplied massively. So this diagram shows you what we're trying to do. We're trying to straighten the spine. And on the left, you can see the way a more natural posture gives you a straighter spine as opposed to a curved spine. And if your spine's curved, your hip's going to be, your pelvis is going to be tilting forward, and your neck muscle is going to be really tight. So is there any evidence that it works? This is the first piece of evidence I'd like to point out to you. How many of you have lumbar pain or have had lumbar pain? Okay. How many of you had Alexander lessons for lumbar pain? Okay, right. This is a GP practice, a real live study in general practice, 600 patients. And what they found was one-to-one lessons in the Alexander technique from registered teachers have long-term benefits for patients with chronic back pain. And they found that actually 6 lessons were nearly as effective as 24. But when you go for Alexander, you probably would, if you had the money, go for 20 lessons, which is not cheap, but it is a life skill. You know, if you were training for a marathon, you wouldn't just do 6 test runs, I don't think. It's the same sort of philosophy, really. So there's a real-life, evidence-based example of how this works for low back pain. The other piece of evidence is the Atlas neck pain study funded by Arthritis Research, big study, and that's published in the Annals of Internal Medicine, and that showed that it worked for neck pain. How many people here have neck pain? How many people here have neck pain all the time? Okay, so there's another example of a modality that has an evidence base that might be helpful for you. And finally, interestingly, these two studies on their own aren't enough for NICE to recommend this for back pain or neck pain, because you have to have a lot of consistent studies. And although these are evidence-based, proper studies, NICE are looking for a whole body of evidence. So this time around, when NICE looked at back pain, they didn't approve it, which is sad. But NICE have approved it for the treatment of Parkinson's disease. And you remember that Parkinson's disease is a movement disorder where you get shakes and you get stooped and you fall over. It's the movement side of things that's helped with Alexander. So that's the evidence as it stands on Alexander technique. And I suppose the best way to find out a bit more about it would be to find a teacher and have a lesson. But we're doing a session tomorrow, breakout tomorrow morning at 11 o'clock with Julie Barber. I don't know whether Julie's got here yet, but she'll be running that session with me. And you might find it interesting to actually talk to an Alexander teacher. So just to put this in perspective, if your physio, if you were a car and your physio was your mechanic, I hope Jane's not here, the Alexander teacher is a driving instructor, teaching you to drive your body differently. And I think that's as much as I can do to explain it to you in these circumstances without you actually having a lesson. So now, where I come from in Kent, we're lucky enough we have got Alexander lessons as part of the NHS pain team, and part of the model would be to roll it out much more widely once we get the evidence base. So, I'm just going to finish up talking a little bit about the Kent project, but Donna's going to talk more tomorrow about the Kent project. This is raising awareness through education and striving for early diagnosis. You'll see a poster outside which summarises our efforts, but basically, we recognise this 10-year maze, which is a quest for diagnosis. It's a massive frustration. Patients go around in circles. There's wasted GP consultations, wasted hospital appointments, lots of unnecessary medications given out with side effects, no diagnosis, and the patient ends up in limbo. This is something I'm sure will resonate with nearly all of you. So the patient becomes unwell as a result of lack of diagnosis and appropriate treatment. And actually we make things worse by not giving somebody the right diagnosis at the right time, because you become increasingly desperate, and then you appear to be hypochondriac, but you're not, because you're only accurately reporting your symptoms. So that's what drives me to change this. Time to do something different. So this is the network. This is my little handout that I give to GPs, which I haven't got in my pocket at the moment, but we'll have some around. I go and talk to GPs, and I take them through this whole scenario. In particular, we've got some nice posters, which I'll show you. There's the iceberg poster. So at the top of this iceberg poster, you can't see it, but it's on the HMSA desk there. All medical students learn about joint pains and stretchy skin, better known as Ehlers-Danlos syndrome, but they don't get any of this stuff that's under the water that we've been talking about here. They just don't get it. And also, they don't ask the right questions either. There's a few simple questions that can be asked. It's not rocket science, but these questions aren't being asked, so the GPs don't get the diagnosis. So what we're trying to do through a series of masterclasses is create a network through education. We're not asking for additional resources. Everyone's seeing these patients, they're just not doing the right thing. Although we might need some resources one day, but the main thing is for the patient and the GP to be, a patient able to go to the GP who knows enough to be able to signpost, probably to the community pain team in our area. That might be one way forward. But most importantly, I think the specialist physio has a central role for people with MSK symptoms. Now, of course, not all of the hypermobility syndromes are MSK. Lots of people are just debilitated by fatigue and POTS and don't get much pain, in which case a different direction is required. The links with the paediatric network, this is a mess, quite frankly. There's nothing in Kent that links up very closely. There's no linkage with the schools. We're very lucky we've got a volunteer in East Kent, Nikki, who's here, and you know, the links with the family, the support groups are starting to emerge. And then over here we've talked about mindfulness and Alexandra and clinical psychology. And tomorrow we're having Chad talk about, he's a clinical psychologist, excellent clinical psychologist, be talking about management of fatigue. And then we need to line up all of these specialists to play the appropriate role and to understand between them. So I go around the specialist departments, and it's work in progress, but it's getting everyone to understand these links, which are obvious to us here, but aren't to them. And then the final poster, there's 3 posters. This is a poster for GPs just to do the basics, because most people with hypermobility don't have symptoms. They are well. They might even be sportsmen like Djokovic or Mark Phelps. It might be an advantage. In fact, we know that it is. But for those who have mild hypermobility, this is a sort of what the GP could be expected to pick up on and do in primary care, because we can't have a situation where a small number of specialists are dealing with loads and loads of people. It just doesn't work that way. And not everyone needs to see a rheumatologist necessarily. So, I'm going to wrap it up now. This is a quote from Albert Einstein. It's not that I'm so smart, it's just that I stay with things longer. And I think, you know, both myself and all the people in the team are going to stick at it. And that's my bit of hope for you at the end of this first day, which I think has been fantastic. And I'd like to give great thanks to Kay and Donna and all the other team who've put this together. I've probably forgotten everyone, but it is excellent to see this. And we can do some questions, and I'm going to leave you with just some resources. I'll leave that up there so you can have a look. Thank you.
Thank you, Philip.